Hello, I'm Dr. Sanjay Wazir. I'm a neonatologist, and in this today's era of COVID, where there's so many seminars and webinars happening, I'm presenting to you one more webinar on office practice in neonatology. And I chose this topic because hardcore neonatology is like where 5 or 10% of people are actually dabbling into, but still, office practice in neonatology, OPD practice of neonatology, virtually every pediatrician has to see. So will try over the next couple of minutes when we talk about in next 45 minutes about the common problems we see and how to deal with them and how to have a scientific approach to the whole concept. Now, I'm not starting in the NICU. I'm not starting in the nursery. I'm starting from the time when the child has to come to the follow-up OPD inside the clinic outside of the hospital. So when we look at a follow-up, what we need to decide, when do we call? Because when we're discharging the patient, we give him a discharge summary. We need to have an approach and a scientific rationale for calling the child over into the clinic. And for that reason, we need to see, it depends upon the age of the child when the child is discharged. If the child is discharged within 24 hours, which may happen sometimes in a very busy hospital where they do not keep the babies, especially for the normal vaginal deliveries, and beyond 24 hours, in that case, we must see the child in 72 hours, even if it is a Sunday. So if you think it's a Sunday and you cannot wait, can't see the baby on Sunday, call him on a Saturday. Again, don't wait for 96 hours, because some of the babies, especially if they have additional risk factors like being slightly premature, like 35, 36 weeks, or a late preterm, not exactly premature, or they have GSPD deficiency, those are the babies who may shoot their bilirubin and then they may land up with connectors. So if the child is between 24 to 48 hours, the discharge age, then they must certainly be called by day 4. And if the child is discharged generally as a cesarean section baby within 48 to 72 hours, by 5 days, he must certainly be seen. The whole purpose of seeing the babies is two. One, that we need to see the baby for the jaundice, and then we also need to see the child for the feeding problems. So we must assess the feeding. So it's not good enough to say, why is the baby feeding well? And the general common problem, common parlance or the dialect we have with the parent, is the baby feeding well? She says yes. And we rely on the judgment of the mother, who has been the mother for the first time, to decide whether she has answered it correctly or not. Instead, we need to have some guidelines to decide how to go about finding about whether the child has been feeding well. And one of the criteria is to look at a baby's weight and the percentage change from the birth. And I'll come to you on that in some time. And also look at the pattern of voiding and stooling. We must look at a clinical judgment should guide us whether we need to do a bilirubin. Just to not look at the baby and decide, oh, it looks yellow and it doesn't look. We'll come to the clinical criteria, how we decide. Check for an occult malformation. Again, I'll come to the examination and assess feeding. So it is good idea to actually have a chart where you have all listed. So I'm just presenting one page of it, but we generally have 2 pages where the first page is all the history and second page is all about malformations which normally gets missed, like heart, like hips, like other things which we normally may miss out in a clinical examination in the first time the child is going to come to us in the clinic. So we must do a full thorough examination, complete naked examination, because we should not rely on only the doctor who's discharged from the nursery to have done the complete examination. And it's important that we need to look at a newborn pee guide on how many times the child passes urine in the first 24 hours, the next 48 hours. And it is said that after day 4, the child should have at least 4 wet diapers. So I don't mean disposable diaper. You can use a cloth diapers as well, but he should be passing or peeing at least 4 times and 4 to 5 times after day 4. And you're passing 5 to 6, then you know that is enough urine is being produced, And if the child is passing that many urine, then at least we are sure that he's having adequate amount of milk from the mother. You could possibly also ask mother some other questions, like, whether she feels the fullness or not. Does she feel that the breast becomes empty after that? So just asking that breast milk is adequate and is feeding well is not enough. You need to have some other criteria. Sometimes you will see a parent coming to you with a diaper like this and saying that there is a blood in urine. So in the first week of life, you will see this kind of a diaper and pinkish orange color crystals on the urine. These are urate crystals and generally would disappear after 1 or 2 weeks. And they are completely benign. No connotation needs to be attached to this. This is not blood. Blood is red and this is orange or pink. The important thing is that many times, as I said, for us to assess the child, we need to weigh the child. So it's important we need to have the discharge weight of the child. Although it's a different machine and every machine would have a little bit of a calibration error, it is important to look at the percentage drop from the time of birth and from the discharge. So most of the times you would gross approximate that 10% weight loss if the child has lost more than 10%, or the child has lost more than 3% weight per day, then there is something which is not going right. If you want to be a little bit more scientific, you would probably have this newbornweight.org, a platform or an online calculator where you plot. If you see here, you see this blue dot and the blue dot. So you have seen the drop in the weight in next 12 hours has been significant. So you know that this child, even if he is symptomatic right now, is going to be in trouble in next 24 to 48 hours, either because of hyponatremia, dehydration, or because of increase in the incidence of jaundice. So always plot the your weight, and if you're not able to plot, at least calculate the percentage loss. When complete examination is something which must do, and always look for small things. Like, for example, in this baby, you would have to look at, if a perpendicular line on the first picture on the left, it is on the air is slightly below that, or in the vertical line along the axis of the air, and if the air is downwards and backwards, then it is either a rotated air or a low set air. And these are the airs, especially if they are associated pits or preauricular tags, or there is a concha or a helix which is not properly formed, then in that case it's important to at least have a more detailed examination. These pointers in itself are not enough for you to say that we should go for a genetic evaluation, but we must do a complete examination, and especially look at hearing, and also look at the kidney status if the antenatal scans are available. Always use a gloved finger to look at a soft palate inside the OPD, because that often gets missed, both by the parents and the examination doctor. And many times, because of the cleft, either the child doesn't gain weight or not feeding well, and sometimes there are choking episodes happening because of this. So it's important to evaluate this particular thing, if not all the things. So when it comes to newborn screening, and I'm not deliberately talking about all the examination, because I know those are the things you would anyway do, but I'm just pointing out only select few which are often missed. When we talk about newborn screening, we only talk about screening which is metabolic. We talked about screening which is Guthrie test, but newborn screening is screening for other things beyond the heel prick, beyond the so-called metabolic. So one of the important things which we all have gotten aware in the last couple of years is the sensory neurohearing defect, which happens in 1 to 2 per 1,000 live births. The so-called who do not have a risk factor, the so-called who may look apparently completely normal, we need to do a hearing screen in every child who's born, and attempt in Kerala is one state where they do it for everyone, and wherever possible we should try to do a hearing screen in every child who's born. There are two ways to do a hearing screen. One is an OAE, an otoacoustic emission, and other is an abbreviated BERA. Abbreviated BERA is also fast and portable, and it is different from a complete BERA. So these are two ways to check the hearing in any baby. So now the difference between the two is that OE cannot pick up auditory neuropathy. Auditory neuropathy is the condition where you have difficulty in differentiating between the sounds or the speech sounds, and this is particularly a problem among the NICU graduates. So for those who are getting discharged from the NICU, you should ask for an abbreviated BERA. For a term baby who's otherwise asymptomatic, you can go for an OAE. Now, the question which people ask is, should everyone get it, or only the risk-based, where there is a admission to the NICU, or there is a previous person with family member with a hearing defect? It is recommended that if you go only with risk-based approach, you will miss 50 to 60% of children with sensory neural hearing defect. And it is important to remember this algorithm or rhyme 136. So any screening has to be done before the first month of age. If the screen is negative the first time, you could repeat the same screen or a different. So for example, if you're done OAE first, either you could do the second screen also, which is OAE, or you can do a second screen which is abbreviated BERA. If that also turns out to be negative, which suggests a refer. So there's only a pass and a refer. So it doesn't say fail. So refer means that you need to do a more definitive test by 3 months of age, by more definitive test by an audiologist. And if you intervene before 6 to 9 months, your chances of developing a normal hearing is complete. So it's important that you need to remember this 136 rhythm. And if you depend only on the parental concerns, that most of the parents would come to you and say, my child listens, and when I call him, when the cooker goes, or there is a noise because of a truck going around the street, he responds. Now that's not a speech frequency. A noise, a sound is made out of frequency somewhere between 500 to 8,000. So if you're responding to noise, you may be actually hearing a high frequency, whereas speech frequency sounds may be completely missing in hearing. And those babies who do not learn in the first 6 months, they do not develop not only a normal hearing and a speech, but they also have a developmental delay, because at the time when sensory stimulus should have been there is not there. So other thing which often gets missed is the vision, and vision is something that we need to just realize, because red reflex is something which we all must do, and many times we so what we do is like use a ophthalmoscope in a dark room, or where the eyes have been hid with a little bit of so you So two things I showed you here. One was in ophthalmoscope, you shine on the light and you see a red reflex coming from both the pupils, would tell you that the pupils are normal. But if you see a white reflex in one side, then it is more like a more like a cataract on one side, or in rare circumstances a disease like retinoblastoma. So red reflex should be part of not only the newborn examination, but after at 1 month also, and like a subsequent month, that you should check for a red reflex in the babies for detecting this. The other thing that you need to look at is a hip examination. Now, it's recommended that all babies must do a hip examination, because hip is often which gets missed, and delayed diagnosis of hip, delayed developmental of dysplasia of hip would result in a long-term condition of osteoarthritis, and the recovery is also not completely. So some people rely on an extra fold, which you see on the leg on the right, or the baby's right, I mean, or a shortening of the femur, which is because of a posterior dislocation. But invariably, what is recommended is that we need to do is like a Barlow's and an Ottoloni maneuver. So I'll just show you. So in the Barlow's test, it's a provocative test. You just make an adduction and try to pull. And if it is a subluxated or a potentially a hip which can translocate out of the socket, but an Ottoloni test is the reverse, which I just showed you. So if you thrust it outwards and push it inwards, then you will find that the dislocated hip would tend to come back into the socket. So if you see a dislocated hip, so in this so provocative, Barlow's test is provocative, where you adduct and push it inwards, and if it is a dislocatable hip, then it will go out. Whereas if it is dislocated already, then you do an Ottoloni maneuver, where you push with a finger with the hip inside into the socket, and you hear a clunk. If you hear a clunk, you know this is an dislocated hip. So an Ottoloni test must be done before and Barlow's test later on. So you check a dislocated hip, bring it into the socket, use the Barlow's maneuver to push it outside. If you pick it, you should certainly send it for a referral to an orthopedician, or at least around 4 to 6 weeks look for a ultrasound for this. The third thing that you would want to check is the congenital heart screening. And congenital heart screening is to pick up certain critical heart diseases which may often be missed, and because the murmurs are not present in most of the cases. So you pick up a disease before the shock ensues or the cyanosis is severe enough to cause a tissue failure. And the best way is to have a pulse oximeter in your clinic. Have a pulse oximeter put on the right upper limb, because that picks up the preductal saturation, and put the same probe on the either of the lower limbs, which picks up the postductal saturation. So the whole idea is to pick up a congenital heart disease, and if you see there is a saturation which is more than 95% in the right hand or the foot, and there is less than 3% difference between the preductal, the right hand, and the postductal, the foot, then that is called a positive. The possibility of the severe congenital heart disease or a critical heart disease is extremely low. So we don't need to really go for any further investigation. But if it is less than 90, as is shown in the red, then you immediately go for an echo and a cardiac evaluation. And it is something which is between 90 to 94, give it more time, and an hour later repeat the same investigation. Or if it is more than 3% difference between the right hand and the foot, repeat it after 1 hour again, repeat it after 1 hour again. If 3 readings have shown you that you have the same result, then it is a good idea to get a cardiac evaluation done by a pediatric cardiologist to find out if there is an underlying heart disease. The whole purpose is, when they're stable, pick them up, so that if they need an operation, they can be operated up in a stable state rather than an unstable state where the surgery would be more detrimental. Now we talk about Guthrie test and expanded metabolic screen, and most of the times the parents, the doctors have an argument: should we offer this because the treatment is not available? That's not true any further now. We have treatment available for most of the metabolic disorders in India. The second argument is that metabolic disease screening is costly. Let's not, as a medical doctor, we need to provide an information to the parents, but we don't need to take financial decisions based on them. for them. So we say, okay, this is available. So somebody may tomorrow say, you did not offer, so that I did not do it. So you offered and say, okay, this is costly, and you want to choose or not. So at least when do you do it? You do it when the child is about to be discharged. Certainly not before 24 hours, because that much amount of milk has to go into the baby to produce that metabolites which can be picked up on the filter paper test. And preterms, you need to do it like right when the child is in, after 24 to 48 hours of feeding, but certainly around 2 to 3 weeks, because there are many false positive, false negative. So preterms, we tend to repeat twice the same test to detect. But for those who say, where the parents say, okay, we certainly cannot do anything, that not the test like this, at least these three, TSH, G6PD, and 17 OHP, is something which you can do, because these have a relatively high prevalence, at least the first two. And the third one can present as shock and is easily treatable if we know the diagnosis. If you don't want to do any three of them, at least the first one, the TSH, because in India, the incidence has been quoted as close to 1 in 990, which means that out of 990 babies, on one baby would have a thyroid dysfunction. And thyroid is one of the easiest treatable cause of mental retardation or neurodevelopmental handicap in the country. So this is something, if you do only the TSH, the cost, depending on the lab, could vary from 100 to 200 rupees also. So if you have a TSH which is high, what do you do any further? So it depends upon whether the TSH is very high. Like if it is more than 80, then the simple thing would be to do a confirmatory test the next day and start levothyroxine, even without waiting for the confirmatory reports to come, or even without meeting a pediatric endocrinologist. If you have a more than 40, then you would need to, after 72 hours of doing the first test, you want to repeat the TSH and the full profile after 3 days. But if you have samples somewhere between 20 to 40, or you've done a sample between 24 to 48 hours, in that case, somewhere between 34 to 40, then you want to repeat the test after a week. If the still TSH is high, more than 20 at less than 2 weeks, or a TSH more than 10 at more than 2 weeks, then you take a confirmatory venous sample again, and then based on that, you decide the treatment. If the T4 is low, you straight away go for TSH high, T4 low, start with the treatment. If normal T4 and TSH in the confirmatory thing, then you could decide this could be normal. And if there is a normal T4, but the TSH is high, okay, you repeat the TSH after 2 weeks again. If the TSH is still high at more than 10, then we will probably start treatment, even if we understand that some of them may be an overkill and there may be a transient thyroid illness. But since the thyroid is every day, which is lost in not treatment of thyroid, would cause 1 to 2 IQ point damage to the brain. So you want to do on the overkill rather than under treatment. Now, jaundice is something which I would want you to talk about, but not the treatment of jaundice. But when the patients come to the clinic, what do we need to do? We need to have this chart of risk factors available to us in the clinic, and you need to tick in front of any one of them. If you have negative answer to most of these questions, then you can be safe that your possibility of risk going very high. And even if you see the baby today, send him home, and the child comes back, the chances of a very significant hyperbilirubinemia is very less, which includes pre-discharge bilirubin. I'll just talk to you in a minute. But if you see a jaundice in the first 24 hours, blood group incompatibility with the positive direct DAT test, which means that if there is an ABO setting, but the jaundice is not on day 3, it's unlikely to be of any significance. But what is more important is that never to treat late preterm babies as term equivalent as far as the jaundice is concerned. So, for example, at 36 weeks, the risk of jaundice is 8 times compared to a baby who is 40 weeks. If the previous baby has received phototherapy, this child requiring phototherapy is also high. So always look at a risk factor, and you see, you probably may have seen transcutaneous bilirubinometer. If you have, but since in the clinic practice, this may be something which is difficult to procure, but at least to have a financial viability, because it costs around 3 to 3.5. Although the cost per test is around only 1 to 1.5 rupees. So you could simply use it, but let's not. There are other modalities nowadays people are trying in different parts of the world in terms of finding whether with a screen card put on the baby chest and using simple phone can actually help in finding out the values of jaundice, as something which we is not been validated now, but for sure is going to come in the near future. But if you get a bilirubin test done, so when do you get the test done? If you see that the jaundice is on the hand and the soles, go for the test. If the jaundice is beyond the thighs, go for the test. Or sometimes we do a prediction nomogram. We do the test, and even if you have slightest of doubt, you plot it on these prediction nomogram. The one on the top is the transcutaneous one on the below is the child who has a serum bilirubin done. So you plot, and there are different zones: the high risk zone, the high intermediate zone, the low intermediate zone, and the low risk zone. So based on that, once you've done, so you see, assess if the child is in the high zone, you evaluate whether the child is requiring phototherapy. But even if you had done a phototherapy now, a scientific rationale would be to repeat this in next 12 to 24 hours. If the child is like in the low zone and it is less than 72 hours, you call them after 2 to 3 days, because the risk of requiring jaundice phototherapy is extremely low in this condition. In the high intermediate zone, check definitely after 24 hours. In low intermediate zone, if you're discharging less than 72 hours, then you need to call them after 2 days. If it is more than 72 hours, then you can simply feel reassured that the risk of jaundice increasing in the low intermediate group after 72 hours is extremely uncommon. So for the treatment, you have a chart, and which is easily available. So rather than going by guesswork, just look at the values. So there are certain, so for Indian babies, because we think that we have a slightly higher incidence of jaundice, we have a higher incidence of G6PD deficiency in the general population. We use the one line below than the currently recommended in this graph. So for example, you see the top graph is for 38 weeks and well, but we use this cut line because this may be a little over treatment from the AAP guidelines, but we think that this is, in a scenario like India, it is safer to use a one line, a threshold which is slightly lower than the recommended by AAP. And when you're use a total bilirubin. So if you have a total bilirubin of 18 and a direct of 1.5, it still remains 18. It's not 16.5. You have different tools available for you to check the jaundice. You can use a bilirubin iPhone app like a Billy Tools, or you can have an Android app, Billy app, where you can plot the weight of the baby, the decision of the baby, and then risk factors, yes or no, and then decide about whether the child would need phototherapy. Before I go off the topic of jaundice, you also must remember the jaundice we talked is only the unconjugated jaundice, but we also need to know about a jaundice which is when the parents come to us on second or third week. There are two kinds of jaundice. One is the conjugated jaundice, one is the unconjugated jaundice. The conjugated jaundice is the one which is because of impairment of either the liver or it is like some other significant disease. And the simplest way is to keep this chart in the ready in your clinic and ask the mother to compare the color of the stools with any of those colors. The one on the top, the clay color or a dark, thoda mitti wala color jo hota hai. So if that is there, then you think that this is possibly an obstruction to the flow of bile from the liver into the intestine. If you have the green color stools or the yellow color stools, this is a child who is probably having a flow of bile from the liver into the intestine. So at least your chances of having an extra hepatic biliary atresia or a significant neonatal hepatitis is very rare. So, many parents come to us with a prolonged unconjugated jaundice in the second or third week of life, and most of them are so perturbed because everybody's been talking to them that the jaundice is not going down and that the mother feels so stressed. So, what do we do in such scenarios? Because the common problem is that we need to rule out conditions like congenital hypothyroidism, galactosemia, urine infection, hemolysis, and G6PD. And at 3 weeks, I would like to do these tests to rule that out and look at treatment guidelines. There is no need to treat the babies unless it is more than 20. So at second or third week, if your bilirubin is 18, please do not treat this baby. But you need to see what do we do. If it is less than 12, do not do any of the tests which I mentioned, and do not do any phototherapy. You just need to do is to reassure the parent that some 10% of babies would have a jaundice prolonged up to approximately 8 to 10 weeks. And that is the time it requires for the liver to mature in those cases. If it is between 12 to 20 milligram, you evaluate for causes but do not treat. But if it is more than 20, you evaluate for the causes, and because most common cause in a well child is a breast milk jaundice, some people may consider cessation of breastfeeding for 24 to 48 hours. But again, if the parent is motivated enough to continue at 20, in that scenario, I may consider treating with the phototherapy and continuing with breastfeeding. But some babies, like especially if their panic levels are very high, you may consider cessation of breastfeeding for 24 hours. Now we come to the general problems we see in the clinic on the day-to-day basis. We talk about, and I'll talk about some of the things which we see very often. So this is an examination finding which often gets missed in the baby at the time of discharge, and even after the baby has visited us in the clinic multiple times. And the parents would say while wiping off the diaper, oh, there is a hole there around the anus, and when you see, this is a sacral dimple. This is part of a spinal dystrophism. So the only thing we need to find out whether this hole has a connection to the spine and is a part of what is known as tethered cord syndrome. So whether this simple sacral dimple is significant or not, we need to have certain characteristics in mind. The characteristic says you do a child to look for a cutaneous stigmata. So if there is a hair tuft present on there, or there is a hematoma or a significant discoloration present on that particular spine, then you would see and go further. If and you do a neural examination, if the neurological examination is showing that the tone is fine, the dribbling of urine is not there, the stool passage is fine, the spinal anal reflux is fine, then you can just wait it out and do nothing and look at other characteristics. If the pit between the anal opening and the pit is more than 2.5 centimeter, or the depth of the pit is more than 0.5 centimeter, then we need the ultrasound of the spine to be done, or if the hair tuft is present, or the abdominal neuro examination. The ultrasound of the lower spine is significantly reliable for us to pick up whether there is a tethered cord. If there is a doubt on the ultrasound, then we should go ahead do the MRI, not MRI in all cases. Now, umbilical So first one on the right hand side, you always should look for whether there is two vessels or single umbilical artery. And if there is a single umbilical artery, you need to be more aware. It doesn't mean that all children should undergo an ultrasound, especially if they haven't had an ultrasound in the antenatal period. But presence of a single umbilical artery would also suggest that you should keep an eye on CVS, GI, and the renal anomalies as a part of an examination. So if the child comes with the polyp or a granuloma coming out of this, because most babies, the cord falls in 1 to 2 weeks and it becomes dry as been shown in the center picture. And once you're done, it falls off and the area remains dry. But if there is a fleshy reddish mass which is coming out of the umbilicus and there's a discharge, it could be a polyp or it most likely is a granuloma. So although the traditional teaching is use of a silver nitrate cauterization, but that is generally not available. The sticks are not available. And if you apply silver nitrate to the surrounding with the finger or with earbuds, they tend to cause burns around. So you use simple salt, the common salt, and apply it once or twice in a day. And you would need to be, treating. Once you do it, it shrivels on its own. And this fiery looking umbilicus is an umbilical sepsis, or it's probably going to go and form a necrotizing fasciitis here. So any presence of a red erythematous painful swelling of the umbilicus should prompt for a intravenous therapy. There's no role for an oral therapy in such cases. So, these are some of the ones which you would probably seek from this depression angular oris absence. Always evaluate the CVS, the rash on the stain on the ophthalmic division of the trigeminal nerve. For twin sign, keep a check on the seizures evaluation. If need be, you may need to do the neuroimaging. And this a hole on the head where the skin is formed is aplasia cutis, again to be associated with some of the genetic syndromes and with CVS. So always keep those in mind. The biggest thing which we often see in the practice is heart murmurs. Now, if you look at the diagram on the your right, the black and white, the bars, it shows almost for some of some coarctation, for example. The coarctation before discharge gets picked up in only 40 to 50% cases, and most cases get present after discharge, or some of them may be postmortem also. So the sicker ones, especially those who have a delayed presentation, may actually get presented late. And this is why, as I said, the screening for a congenital heart screening with a pulse oximeter in the right hand and the lower limb is something which is relevant. But at the same time, 50% of murmurs in the newborn period are innocent, generally because of a peripheral pulmonary stenosis or a kinking, closing PDA, and a still murmur. And most of them would resolve over a period of time. But you also must realize that absence of a murmur does not rule out a congenital heart disease, because in 50% you will not hear any murmur. So if you hear a murmur, the approach should be to look at like any of one of those. If it's a green column or the square, if you focus on the well baby, there is no signs of CCF. The pulses, both the brachial as the femoral, are normal. There are normal saturations, upper limb, lower limb, and the murmur is very soft and grade 2 to grade 3. Then in that case, you would not need to evaluate further. But if there is signs of heart failure, shock, saturation difference more than 3%, absent of weak femoral pulses on the red column, then immediately admit to an ICU, maybe talk to the pediatric cardiologist. In case there is a loud murmur more than grade 2, which is the most common scenario, or you see a pansystolic, if it's an early systolic, or it is a continuous or a pansystolic murmur, or a location which is outside the lower sternal edge, and with an abnormal EEG and with an dysmorphic feature, it's not an urgency, but refer to a pediatric cardiologist for him to evaluate whether the child has additional significant disorders. Rarely you would probably see children coming with Earth palsy, and the parents ask you the question, would the child recover or not? Most of these babies, 90% of the children would have of the incomplete plexus injury would recover. So prognosis largely good, but if the recovery of biceps happen by 1 month of age, you probably can reassure the parent that everything is going to be fine. If there are no response happening by 3 months of age, then further recovery is unlikely, and then you probably may have to consider other modalities like nerve transplantation and other things. So, although colic is one of the reasons, but I believe that we have already had a session on colic. We'll see what are the other causes. Why do babies cry? And many times you'll get a baby coming to the OPD, the child बहुत रो रहा है जी, रोता ही रहता है, like, so then we'll see, okay, the children are crying because they're ill, they have, like, they may just have problem, they're cold, colic, or sometimes the hunger. So we need to see what is the systemic evaluation, how do we go about. So any child, we should have this chart available to us and go from top to bottom to find out whether we need to see. Sometimes there may be a hair tourniquet, or sometimes a diaper pin poking. So I'll not go into details so probably, but you need to see all the systems from skin to eyes to nose to cardiovascular and GI, because and then genitourinary, and of course the neurological systems, to find out if there is any kind of a organ which is affected and is causing the pain and discomfort of the child. But you must always, if in a quick examination you would want to do, if you have a distended abdomen, you have a fever and a child who's lethargic, then that probably has a significant implication. So in that case, you should go for a not go colic here. Okay. Okay, so the last two bit, I'll go with the diaper dermatitis and the seborrhea are the common things. So many children would present with this kind of a cradle cap. Generally doesn't start early, but generally by 3 to 4 weeks, and many babies would develop a flaky, greasy scales on the head, which go behind the ears. And sometimes, if you see this baby who is supposedly was diagnosed as atopic dermatitis, is when there are lesions predominantly in the flexural areas and the folds, then it is more likely to be seborrheic rather than atopic dermatitis. And in that case, generally, if it is not causing discomfort to the child, the parents may choose not to get it treated, but and just use an emollient. But if it is causing too much of a trouble, or the parents so desire, you can use a shampoo, like a non-medicated shampoo, to help. But the way to use a shampoo is that you use a shampoo, rub it into the scalp, and leave it there for 2 minutes. Every shampoo detergent needs a contact time, so leave it there for 2 minutes, and after that you just use a hairbrush to scrape it off, and then use it on an alternate day, or day after, bi-weekly, and then once it improves, you could still continue using it once a week. If non-medicated shampoo doesn't work, you can use a ketoconazole shampoo 2%. And if there is a lot of inflammation, you will use a hydrocortisone 1% cream, but don't use a steroid cream, which is very heavy. So important thing you need to understand as for the diaper dermatitis, because this is again what gets presents to us, is an excursion of skin. So you see some of the times may be very severe, but if you see this schematic diagram, the folds are spared in diaper dermatitis, which is not candidal. So these are also some of the rare, forms and severe forms of diaper dermatitis. But when it comes to prevention and treatment, this is because most parents would ask us this question: A, B, C, D. Simple. A is at least keep it open to air for 1 hour. Use a barrier cream, and barrier cream is the diaper cream So you usually would want something for 10 to 15% zinc oxide would prevent a good barrier function. So many creams are available which use 4%, 5% zinc oxide, and they sell as diaper creams. But it is important to have a consistency which is thick, because it has to act as a barrier between the stool and the skin. So you apply it like a toothpaste, for example. You apply on the skin, it forms a thick layer. It should form a thick layer so that next time the stool doesn't come in contact. But it is severely inflamed, use a low potency hydrocortisone 1% cream, and remember, change the diaper every 2 to 3 hours. As of now, there is no data to suggest that cloth or a disposable, which one is better. So people keep on discussing. My mother said use cloth because diapers would cause more diaper rash. That's no longer true. If you change it every 4 hours, disposable diapers are as good as cloth nappies. So it depends upon the preference of the parent, and also the cost involved in using. So experience involved in using the diaper. Oral thrush is something which we seek very commonly, but the important thing is that you use oral antifungal drops which are commonly available. It's generally seen in bottle-fed babies, and if there is a recurrent cases which happen again and again, then you may choose to use fluconazole at a lower dose than what is recommended for the treatment of invasive fungal infections at 3 milligram. But sometimes what happens is that even the breastfed babies get colic. And if they get a colic at that point of time, just remember that you must get the nipple examined by the gynecologist. But in case it is not possible for, or in a busy, one simple clue to the diagnosis would be the there is a redness on the nipple, or the parent may not complain of a redness, but the pain is excruciatingly high. So pain disproportionate to the look of the lesion is a sign of a fungal infection of the nipple, and that's why that some of the breastfed babies may be developing rectal thrush. So in that case, you need to use a 14 days course for the mother, oral fluconazole on day 1 400, followed by 200 milligram every day for the next 14 days that you need to be doing. And this is something which we have to hear every time: congestion word, noisy breathing. And this is the last slide I'm going to go before, because this is nightmarish for the doctors to listen, because unka zukam kabhi khatam hi nahi hota. It's like, so before that, how to go about it is like, the common tips we wanted to discuss with you. So one of the common tips that you need to do is like to use a nasal aspirator. So it's commonly available. So either you use something like a Deeley's mucus aspirator after putting in a saline drops. So always remember the saline drops. I'll just show you in a minute like how we need to use a saline drops in the babies. But
so on phase by them, she's like more bothered about the sneeze that comes after having the drops than the actual spray or drops themselves.
So
they just really, really work well. Sure,
so you need to put the saline drop in a sitting position, not in a lying down position, and that's commonly like, either is make the child sit or on the shoulder like this, and then spray it inside, because most of the good nasal sprays have a spray, and it goes like a fine spray into the nose and a deeper part of the nose, and causes, where you put it in the lying down position, the drop invariably does not go into the nose. So after that, you've cleaned the sprayed into the nose, you can use a nasal aspirator. The baby may be more comfortable when you put him sleeping in this position, although you don't recommend a supine position prone position for sleeping for long. But in a slanting position, sometimes the babies feel more comfortable. Giving a steam is not an option in one of the places, but what you could recommend is going to the washroom, keeping the shower on, keep the ventilator off, sit in the washroom after you've allowed the shower to attach to the geyser to fall down on the screen on the floor, and that emits it's more like a steam bath which the child and the mother can take. Always keep the child slanting when you're making the child sleep by putting a blanket or a pillow underneath the mattress. Otherwise, the child would, if you keep only the head pillow, the child would flow down. And use a cold humidifier, which is available. So you get a cold humidifier and a hot humidifier. You need to use a cold humidifier because that emits water vapors at a room temperature. It's not water vapor, it actually is the mist. So it's a mist which it releases around the baby, keeps it humidified, and makes humidified air is easier to breathe than the non-humidified air, which is generally a problem because of the ACs which we use simultaneously in the baby's room to control the temperature. So thank you so much. I've been talked, so I could not cover all the topics, but of course, in a short period of time, I thought I'll probably touch upon some of the common ones. But if you have any questions, I'm happy to answer many of them. So I'll go through the questions like right now. When do I start supplement of vitamin D and iron in term and preterm neonates? But Dr. Rakesh is asking. So for vitamin D, you should start as soon as first we talk about the term babies. For the term babies, you need to start right at the birth, or maybe after a few days, like in the first clinic visit, and then you continue till at least 1 year, or at least you think that the child is getting enough vitamin D from the sun by going out, and when the child is mobile. Till the child is not mobile and is likely to stay indoors, it's a good idea to continue with vitamin D. Iron in term babies, you generally start around 4 to 6 months, because till that time the breastfeed bioavailability of iron is quite good. But after that, because the Indian diets tend to be lower in iron, and the Indian formulas also tend to be lower in iron, so it's a good idea to start around 4 to 6 months. By preterm babies, you start vitamin D early. Most of them would have started in the NICU itself, and most of the very small babies you would have started iron also at that time. But generally, for relatively bigger babies, around 2 to 6 weeks is the time when you will start iron. And in preterm babies, you need to continue it for approximately 2 years, 1.5 to 2 years, because of the large amount of accretion of iron happens in the third trimester. And if they're born very premature, they do not have that iron stores available to them. Any role of drugs in spitting of milk, PPI versus sucralfate versus digestive and carminative drops? Okay, so regurgitation is seen in almost 30% of the babies. And if you see the incidence of regurgitation keeps on increasing. So if the child is regurgitating at 1 month, the incidence and the amount of regurgitate would increase by 4 months. The peak happens around 4 to 6 weeks. So you need to reassure the parent about the difference between a regurgitation and the vomiting. Vomiting is projectile. It leads to lesser urine output. It leads to weight loss, and eventually, if it has been persistent, it is bilious, would need to be treated with all those things that you said, PPI, sucralfate, whatever. Generally, we don't use sucralfate in newborns. But anyways, on the other hand, regurgitation is something, if your baby is gaining weight, if the baby is passing urine adequately, is a happy spitter, throws up and he feels, that is how the cows also behave. And that is all small mammals would behave. And regurgitation should not be treated, even if you look. But I understand it's sometimes difficult to convince the parent that this is not to be treated and you can be leaving. But eventually, if you talk to them in a calm environment and reassure them, they would probably listen to you, especially when they see the weight gain is happening fine. If you're using a formula, then in that case, sometimes using a partially hydrolyzed formula is sometimes which benefits a child. But if you're using a breast milk, then you don't need to do any intervention. Cause and treatment of evening colic is something that has been asked by Dr. Rakesh. The cause, nobody knows. Treatment, again, you would try all the things, but at the time you would not find the last one which you used, you will think that is the one which probably made the difference. Colic, you need to treat, you think there are certain dietary things in the mother's diet you can change, there are certain general measures like, and like, and third, you would need to see there is a child where the drugs would come in. Drugs are least likely to be effective, but most commonly used. Among that, like people use samimethicone, which or carbonated drops. Some people, especially if they have a lot of gas problem with very frothy stools, suggestive of a lactose intolerance, use of lactase drops, and probiotic. I'm sure that has already been covered. But from a mother's perspective, there are three things that you need to understand. If the child has a significant colic and excessively crying, sometimes we try an exclusion diet of milk, nuts, and wheat, because if there is an occult allergy to nuts, wheat, and milk, sometimes that gets passed on and the child is crying, especially if the crying is incessant and very prolonged. So you can try that, and apart from that, general measures you could possibly try. Constipation in term infant, mother said the child is not passing for 3 to 4 days. How to manage and reassure? You must remember that the child may pass once in 7 days. Constipation is hard stools. It is not, infrequent stooling. So, way to reassure, tell the mother, because the milk is there and the milk does not have a residue or a fiber. So it's quite okay for a child to pass stool once in 7 days or 10 days. Unless there is an abdominal distension, do not recommend laxatives or glycerin suppositories. And sometimes the babies strain at the time of passing stool, that could dyschezia, and that is going to be, but they pass soft stools. Again, that does not need to be, managed. All you could do is like apply a little bit of, coconut oil at the bottom to reassure the parents. Intermittent cough in an apparently healthy neonate without signs of sepsis. Generally, it's some bit of a regurgitation, or it is like sometimes the most common cause is dryness because of the AC, and they become dry and it's like. And many times I've seen in my practice, people say this is doing colic and say गले से कुछ आवाजें निकाल रहा है, खांसी हो रही है, and that may be because of the colic. Breast milk and feeding jaundice. Breast, there are two things. Feeding jaundice, breastfeeding jaundice is because of lack of breast milk in the baby, and the jaundice increases because the feeding is less, the dehydration is more, the weight loss is more, and the bilirubin concentration rises. Breast milk jaundice is because of some component of breast milk, but again, as I said, that does not need to be treated. That does not need to be treated as such. Okay, what gestational age you do an OAE? We have to do it before discharge, as I said, before 1 month of age. We should be 1 month of age. We should be lost. Yes, and for babies less than 35 weeks, which chart is more useful for jaundice? I believe you're asking. You can use the NICE guidelines which are available. The charts at every gestation. All the different nomograms available. But NICE guidelines, as I said, Billy app chart will give you every gestation, every day, what needs to be done as per the phototherapy. Question number 10, newborn baby are discharged within 24 hours from the hospital, even after cesarean. Well, early discharge is definitely not recommended. Children should get discharged around, approximately third or fourth day, by the time you have assessed feeding, weight loss, jaundice, and other things. But because of pressure of beds, and sometimes they do get discharged early, but it's important that you call them after 24 to 48 hours again and see them during the broad daylight, and do not call them in the evening clinic, but call them in during the daytime. Chart of neuron examination of cardiac problem. I did not understand the question. Can you just repeat the question again? I'll come to you again. How many times does the normal baby passes urine when the child baby age of 10 months? So it's difficult to say. It's like, but what is important to say, 4 to 5 diapers in 24 hours time. But if the child is not passing urine in the night time completely, that's completely fine. You don't need to, like, many parents are concerned कि शाम को रात को वो सुसु नहीं करता, but that's quite normal. What about using nasal drops instead of spray? Yes, you can do it, but I said it's technically difficult to put the nasal drop into the nose, because you have to, like, in this putting position, you press it, it goes inside. But if the child is lying like this and trying to figure out, most of the time the child sneezes out and the drop doesn't go inside. How long it's recommended to give DHA for preterm babies? DHA drops as such, I do not recommend for babies, because there is no data to suggest that DHA alone with the AR, without the accompanying ARA. So if it is part of a drug formula formulation, or is part of the breast milk, DHA and ARA, then it is good. But the plain DHA drops which are available in the market have no value. How long to continue vitamin D? I also already have answered that, like, that you should give it till the child ambulates. Multivitamin drops have no value, and iron I've also answered for a term baby between 4 to 6. How frequently nasal saline drops can be given? Every 4 to 6 hours. Baby not for passing stool for more than 4 to 5 days, already answered. What to advise when the mother complains of cough so when the child complains of cough, you should ask for an examination. It is not normal for the child to cough, and if he's really having a cough, you should look at whether there is a problem in the throat, or it is like, or there is a reflux which is causing the child to have a cough, or there is like something which is in the chest, or it is like a CCF, something which you, if the cough is not normal, that's what I say. But most of the times it will be like an innoxious cause, like for example a dryness causing a cough. But always examine. Do not advise on phone if the newborn is complaining of cough. Human milk fortifier is only for the preterm babies, not for the term babies. We do not recommend. So you do fortifier only in those which are being discharged, which are in the nursery, and the fortifier is already there. Outside the setting of NICU, you would do only in those babies, NICU graduates, who are not gaining weight. But again, that's a whole topic in itself, so I can't really cover it in a very short period of time. Vaccination in preterm, can it be taken before 34 weeks? Vaccination has to be based on a chronological age, not based on the gestational age. A 26 weeks baby, should get by 2 months of age a vaccine. You cannot delay till the time he reaches. Vitamin D dose in preterm 800. You're just moving a little bit fast, like 800 to or 1000 or more. 800 is good enough, because based on the trials, some people use 1000 also, but like we are comfortable with 800. Probiotics in preterm and when to give from day one. Preterm probiotics, again, it's a complete topic, so I mean I can't really cover it in one sentence, but I would say you can use probiotics if your NICU and NEC rate is quite high. But if it is low, then it's a matter of choice whether you're going to see the benefit. Many doctors are suggesting newborn drops and Woodward drops to prescribe or not to. What your suggestion? So generally, I don't know what this newborn drop is, Ayurvedic drop is concerned, but what I suggest to the parents is like neonatology is newborn OPD is more about reassuring than to say. If you explain the cause of the problem and the general measures associated with it, most parents do not want to give treatment to their try to give treatment to their children. They are not happy with giving medication to their children. But at the same time, I think Woodward's syrup you're talking about is like gripe water, I guess. Like, I don't know, but most the important thing to realize is that most of the gripe waters were coming with the label alcohol free. So at that point of time, you would mean that there were some people who were using alcohol into this, or some people used to use opium and atropine, which causes sedation. So it's not a safe practice to do. I would suggest do not do it. Urine coming out in a streamline forcefully, as what can be the treatment? I'll have to re-understand that question, because urine coming out in a stream is good. If you have an interrupted stream, then you probably are then you have a problem of a PUV. What is the cause of bleeding per vaginum in infant, and what to do? Anum, like I don't know whether you mean vaginum, but bleeding per vaginum is because the hormones which are passed on from the mother into the baby causes a placental withdrawal bleeding in the baby, because it has a female uterus inside. In a female baby, vaginal bleeding in the first 1 week of life and up to 3 weeks is completely normal, and a vaginal mucus discharge, vital discharge, is also uh, fine. What is the role of domperidone to enhance milk in the mothers? Uh, it is it seems to work. Domperidone or metoclopramide, so we is supposed to increase by blocking the dopamine from the brain into the body, and anti-dopamine action of domperidone causes more milk output. But alone this does not work. So there are three more things that you need to remember. One, that you need to ensure that the mother is stress free. The more the stress, the more the dopamine. So whatever medicine you're going to give, you're not going to cause any benefit. Second, you need to have 2.5 liters of liquid, because 1.5 the baby needs for mother needs for her urine production, and 1 liter for the milk production. The third important thing that you need to see is that she's having a good diet, and more importantly, she's expressing. So many mothers say, हम तो दूध बच्चा दूध नहीं पीता, उस आता नहीं है, इसलिए हम बोतल पिला देते हैं, और मेरा दूध आता नहीं है. Unless you express, and there's a letdown reflex which keeps on going again and again and circling, then you will have less of a urine milk output. So isolated hyperpigmented genitalia, how to consult? So when to screen? As I said, like if you want to screen, you should screen for all. Maybe in one of the other topics I can show you, or maybe you can write to me privately on an email and share you. When do you consider genitalia to be ambiguous? And because I can show it now on the screen. When to start bathing in full term and preterm in summers and winters is Piyush's answer. Now, bathing is something which you can wait, although there is no contraindication to bathing even on second day. Some hospitals do practice bathing on day 2, day 3 itself. But in my practice, what I do is like tell the parents to wait till the cords fall off. There is no scientific rationale for it. The only thing what it does is, because the apprehension in the first few days is too high for them to cause more mistakes while bathing the child rather than benefiting the baby. Unless there is a visible soiling with the blood or a feces or something that you are grossly contaminated, you won't want them to do that. And when you bathe the child, you should make sure that the other thing where you want to delay is that the breastfeeding is yet to be established. The child may become hypothermic because the skin is like not completely mature. So you would want to delay till the cord falls off. But when you bathe, there are two principles that you need to remember. The water should not be very hot, but it should not be very cold. So both ways. So you put your finger inside, and if you can hold the finger and you feel like a normal tap water during the summer months, then it is completely fine. So slightly on the lower side is still better than very warm, because it causes skin dryness. So if it is cold, then you bathe inside the center of the room, not the side, because there is a radiation heat loss happening from the sides. So it's important to bathe right in the center, where the radiation heat loss is lesser. And if it is winter months, then you could do part by part. So first you bathe the upper part, then the lower part. So uncover the baby half by half. Is there any data to suggest that we have to use lower bilirubin? No, as I showed in the slide, it's a personal choice. I mean, you can choose the AP criteria for the phototherapy, but as I said, like, because many of our babies, even when we see a routine OPD, many of them have not get the full tested done for G6PD. Many of them maybe HA babies where the level of treatment is generally recommended to be 1 to 2 degree lesser. They are the babies. Very few of them are HES. our population 20% are HEA. So that's why we use one line blower. But again, as I said, it's a personal choice and personal preference. Lots of vitamin D brands are available in the market, and pack is written 200 IU and it's written 800 IU. You need to give 400 IU per day in the first year of life. So you can just see and trust a brand which you have been familiar with. What is your take on oil body massage? Now, this is again, I wanted to include in the skin, but possibly a time I could not. But massage is something that you possibly can do. It helps in two things. One, it increases the bonding between the mother and the baby. So it should be done by the mother, not the caretaker, because you do not want to increase the bonding between the caretaker, the dai and the baby. And the other thing is that the oil massage helps in improving the skin blood flow, making the child calmer, and there is some data, especially in preterm, that it helps in better neurodevelopmental, by decreasing the stress levels. BCG-induced lymphadenitis, most of the times you don't need to do it unless there is like a rupture. You can just tell them that most of them, if there is a swelling, it will go down over a period of time. And the very reason we give it here because we can pick it up. What young people need PPI? I didn't get the question. Can you repeat that? What children need PPI? PPI is not required unless you are dealing with the GARD. GARD, if the child is crying, if you'd have to differentiate between three reasons. One is like the reason is like the child is crying because of a colic, in which case the child is crying during the night time or evening time, and during the day he's relatively stable, otherwise well thriving baby. GR babies and CMPI babies, cow's milk protein allergy babies, are fretful and crying throughout the day. And one characteristic feature of GR is the arching, because to reduce the acid flow into the esophagus, they arch backwards. And if you have, then in that case you would probably use an PPI. Role of Smile MCT, pure MCT powder for weight gain in preterm babies. Do not use it, because when you look at growth, and why Smile MCT is not recommended, because it increases only the fat. There is no protein. Whereas for gaining, you want to gain a linear mass by increasing the muscle mass and the bone mass. But with the oil, you're only going to gain weight. So your weight, because of the fat deposition, which is of no value for an individual. So I do not want to gain weight by putting on fat. I want to gain muscle. I want to gain bone, because that is going to help me longer. So that is why for a short term, some people use Smile MCT, but only to discharge babies from the NICU, but it has no value and no longer recommended. Baby born to COVID positive mother, should we give BCG? Yes, I think last week there was NNF, lecture on this. I think you can contact Dr. Anup Thakur. He'll give you a PowerPoint how to manage babies with COVID positive. But vaccination is not to be delayed for COVID positive, mothers delivering babies. 1 month baby is vomiting again and again, and weight loss is happening. What can be done? So vomiting in a newborn is something which we need to see. If the weight loss is happening, then you need to find out the cause for it. So the cause could be surgical, medical. So medical could be like an infection, or maybe sometimes the renal failure, sometimes. So you need a full evaluation rather than saying what can be done. You need a full evaluation. It could be, if it is the bilious vomiting, for example, then it could be an obstruction or a partial malrotation, for example. It is a non-bilious projectile vomiting with a weight loss in a 1 month, especially a male child. It could be a pyloric stenosis. So do a full follow examination, and then that answer can be. Treatment of dehydration fever for babies: increase the fluid intake by giving more fluids. So, if the baby is breastfeeding, increase the breastfeeding frequency. If the baby is not breastfeeding, increase the top feed frequency. But there is no role for giving water to treat dehydration fever. Gripe mixture is not okay. We just answered that, when and how much time the diaper should be used. You could choose between cloth nappy and the diaper, which is the disposable diaper. the incidence of diaper rashes are equal with both of them. The current generation of diapers are better than the previous generation diapers, so they cause less problem. But remember, if you're using a diaper, you need to air the skin by changing it every 3 to 4 hours and keeping 1 hour diaper free during the day. Anytime that you need to do uh, rationale of using airdrops in infant, are they helpful? I mean, there's no rationale for using any airdrops, but that is known as a cocktail therapy, which most people, some pediatricians try. If the child comes in the night and they do not know what they're, so they give him a crocin. They thinking कि अगर fever है तो वो ठीक हो जाएगा, कान में दर्द है तो एयर ड्रॉप चलती हैं, colic drops भी इसमें. So you will see all that prescription because they come in the middle of the night, and this is generally what happen when a busy hospital gets a patient in the middle of the night and the resident doesn't want to examine. So that's where where it goes, but there's no rationale. If the 6 weeks baby is missing vaccination, is it going to risk for the baby in this lockdown? No, in fact, now the ACIP recommendations have come that we should not delay the primary vaccinations at least in the 6 weeks, 10 weeks, and 14 weeks. And the measles vaccines are some which very, very essential. So if there is a lockdown, you could figure out ways to give the vaccine. So you should still run your clinic. First half of the clinic, you should do the vaccination where you call only the children who are not sick. Then treat the second half of the clinic. You should treat the sick patients with fever, with cough, or anything. And before going home, and that evening or afternoon, till whatever time you run this clinic, clean it, do the proper sanitation. At second day morning, again start with the vaccination. But do call children for vaccination. Do not delay it. Bloody stools in the neonates, what do you suggest? Now, blood in the stool is not a normal finding. If it is true blood, you need to find out. Then there could be multiple reasons why the child probably has a blood. And the reasons could be in the form of in the form of surgical or in the medical form. Most common in a child who's otherwise well is either a cow's milk protein allergy, and I mean, say the baby is otherwise thriving well, but the blood lower, is because of a cow's milk protein allergy in the newborn period. Especially if you have seen, it is not because of a swallowed maternal blood in the initial 1 or 2 days or 3 days. The anal fissure because of constipation is another reason. You could probably look at Hirschsprung disease causing this kind of a problem, but always examine the rectum and always look at a history of cow's milk. So if the child is thriving well, most of the times you're stopping the cow's milk formula and replace it with the soya or hypoallergenic formula, or if the mother is only on the breast milk, stopping the cow's milk intake in the mother sometimes can help the cause. If it is still persistent, then you should go and ask the gastroenterologist about this. Rash-free creams should contain what? Basic component. Piogen asks, rash-free creams should contain, there are many soothing agents, calendula and other things, but the basic essence is zinc oxide cream. And zinc oxide cream for prevention purposes and for treatment purposes is two different. Like, for example, I just named Desitin. So it comes in two forms. So 10 to 15% cream is for prevention, and if you want to treat, then you need 40%, 30 to 40% strength of zinc oxide in that particular diaper cream. I'm sure you're talking about the diaper cream only, So that is something which you can use for the rash cream. Whether the formula given to the newborns in first few days should be given. No, you should not give formula to the babies because there is a weight loss or inadequacy of breast milk. Because inadequacy is in the mind. No other mammal except for humans have to give extra feed to their children. So the only special circumstances you may be fine, but a primary gravida mother should be able to produce, a good amount of milk in second or third day. In the first 2 days, the requirement of milk is small because of a smaller stomach size, and as the size increases, the days increase, the size of the but the milk flow also increases. That's a nature's phenomena. So you need to find out what is the why the breast milk is inadequate, or it's like stress. And we just talked about some of the reasons why the children would have less breast milk, and you can go back and say how much omeprazole sachets are helpful in GR. So you can GER does not need to be checked. Gastroesophageal reflux is normal. Gastroesophageal reflux disease is abnormal, and where you may just want to use 2 to 4 weeks of PPI to find whether they're going to be beneficial. But just because he's regurgitating, happy child, happy spitter, weight gain is fine, the child is doing fine, you do not need to do any medication. Just reassurance is fine. If the child is having stool output in an alternate day of 3 days, it's normal even after 7 to 10 days. If the child is not having an significant abdominal distension and is not crying excessively, it's quite okay. Cord TSH in twin to triplet delivery, how much should we consider significant? More than 20? I just said, more than 20. As of now, there is no data to suggest that triplets. At least I'm not aware. Maybe you can just confirm with the pediatric endocrinologist. But whether triplets or the twins, they need to have a different cutoff for TSH. So more than, as I said, simplistic is 20, 40, and 80. If it is 80, take a confirmatory sample, start treatment. 40, you can repeat it after 3 days. 20 and above, repeat it after 7 days, and then you will have an decide further based on the chart which we need to. Eye discharge in 1 month baby, do we need to treat or wait and watch? So eye discharge in the babies, 90% of the eye discharge in the babies of 1 month is because of a blocked tear duct. So that is because the tear duct carries the tears from the eye into the nose, and if it is blocked, it tends to overflow from this thing. And important thing is for you to look at the eye. If the eye is not red from inside, it is like just mucus collecting here or the water collecting here, then in that case, it is more likely a nasolacrimal duct block. If it is eye is red, then you obviously need to investigate further. The easier way is to look at this and look at massage. And many people have different ways of finding massage. The best way is to look at, you go from inner, lower eyelid towards the inner canthus. At the inner canthus, you pull it down, because, or if you have a doubt, you can look at the anatomy of the nasolacrimal duct on the Google, and you see you need to pull it down and use firmly. Use it 3 to 4 times in a day for 3 to 4 months, despite the improvement, because there is recanalization is common. And do it 10 minutes after the feeding and 10 strokes at one time. After the feeding, because that's the time when the child is most quiet and easily amenable to any manipulation. I decided daily sanitization by which agent? I do not get this question, but I believe you say, should we sanitize routinely? Well, sanitizing, over sanitization is an overkill. Many times, you don't need to clean, and unless your hands are completely soiled with feces, then you need to, child's feces, you need to go and wash, because organic material cannot be washed out with sanitizers alone. But if you have you soiled somewhere and you're making a feed for the child, or you're feeding, then in that case, washing hands with the sanitizer, the 70% alcohol which we use in the hospital, is quite okay. After giving birth to a small child, there is a red granuloma on the level. How can I solve the problem? So after giving the birth to a child with a small or big, the red granuloma on the navel is either an umbilical granuloma or an umbilical polyp. So what are the things, as I said, like you clean that discharge or whatever pus-like material from there with the sanitizer, and use this finger, just a common salt you spray on the tabletop, apply it here, and apply it on the granuloma. Just do it once a day for 7 to 10 days. This will 99% would shrink with this. If it does not, then you should seek a pediatric surgical opinion to find out whether this is something to do with the umbilical polyp, because that is something which is surgical correction. Polyp cannot be treated with medical therapies alone. Okay, thank you. It was lovely having you all, and it was nice, and so many questions that I probably went a little fast. So maybe some of the things which I could not answer. Probably, if you have any questions, you can get back to me. And my only suggestion to you is stay safe. Take all PPs when you are seeing patients in the clinic, because once you remain safe, the India progresses. So I would suggest stay safe, stay home, and go to the hospital, wear PPE, and do some other reason. I know there's a lot of webinars happening, so somebody was asking. So we read so much these days, but there are hardly any patients to apply this knowledge on. But this knowledge hopefully would come to use in some time when you have patients coming back again. Thank you so much.